Coming back, second case, elderly male with multiple comorbidity. The history wise, there will be lower respiratory tract infections. What I am trying to tell, there will be purulent sputum with dyspnea, tachypnea, everything there. Your examination also there will be favoring for pneumonia, lower respiratory tract infection, even crackles on the left base. You are going X-ray. X-ray is unfortunately not here. There will be lower respiratory tract infection. Now it's left lower lobe pneumonia. Coming to examination, even radiological findings are favoring. Even ESR, CRP, everything higher sides. Now what antibiotic you are going to choose? Amoxi or amoxiclavo or piptas or meropenem, or otherwise are told like levofloxacin, or something else you want to choose, vancomycin or extra cefuroxime are told. Ma'am? Three means piptas. Any other? Amoxicillin plus gram negative you want to give, sir? Gram negative. Any other, sir? Sir? It's nothing wrong, sir. We are right or wrong. Even if I am asking to about plastic surgery or something else, I don't know. Meropenem, sir, told. Super, penicillin, super. The upper respiratory tract infection I told, when need to give antibiotic. Lower respiratory tract infection means there will be lower lobe pneumonia. There will be predominantly bacterial. What we are going to deal? Bacterial means what bacterial we are going to deal. There will be atypical or typical infection. It will be typical pneumonia. Lower lobe is atypical means bronchopneumonia. Is typical means lobar pneumonia. Lobar pneumonia means what in India most common cause for pneumonia. What bacteria? There will be only few bacteria will be common, everyone know. Sir? Streptococcus pneumoniae, pneumococcus. Then, yes sir, exactly correct sir. Penicillin it will be answer. Problem nowadays there will be like our patient coming with multiple comorbidity. Repeated use of penicillin. It's available, sir. Available, sir. Everything penicillin available, sir. There will be answer is here will be amoxiclavo and acitro. There will be like answer is why I am telling amoxiclavo means answer is you told like streptococcus pneumoniae, pneumococcus. You will give lower drugs or either amoxi or amoxiclavo. Like our patient there will be comorbidity is there. Then it will be considered amoxiclavo. No comorbidity, go for amoxicillin. Even acitro is not needed here like way. Suppose patients coming to you viral you are suspecting means there will be oseltamivir you need to consider. Atypical means acitro or doxycycline or sort of like levoflox. The resistant it will be different topic, it will be a different thing. At least you know atypical or typical. X-ray wise there will be lower lobe pneumonia, your examination also favoring, your diagnosis pneumococcus infection. Then here you will go to give community acquired pneumonia. Suppose patient admitted in more than 2 days in hospital, then consider as hospital acquired pneumonia. That time you need to consider gram negative infection more common. Then we E. coli, Klebsiella, Pseudomonas, even Acinetobacter. If you are going to see community acquired pneumonia, there will be Streptococcus pneumoniae. Otherwise, you need to consider about MRSA, methicillin resistant Staphylococcus aureus. Otherwise, you need to consider there will be Pseudomonas, repeated older admission, very sick patient. That time you need to consider. This thing you need to consider. Where we are dealing like that. Sir, for MRSA your suspecting means vancomycin you need to consider. In ICU patients, but like stable patient it will be linear. Why I am telling that one I will come. History was short duration, sir. History short duration. TB it will be different, sir. Piptas or meropenem you are going to give means hospital acquired pneumonia. Patients coming to you for community acquired pneumonia, you are going to give piptas or meropenem, it is not going to help. Either ceftriaxone or amoxiclavo, amoxicillin, amoxiclavo resistant means you need to consider vancomycin. Even it will cover MRSA. Lower respiratory tract infection means anything below the larynx. You need to consider Atypical pneumonia, Mycoplasma, Chlamydia, Legionella. These things you need to consider. Whatever I told, same thing only. Comorbid patient, non-comorbid patient, MRSA, Pseudomonas. Whatever I told, same thing only. Third case, there will be elderly male, no comorbidity. The symptoms wise there will be UTI. There will be burning micturition is there, line pain is there, fever is there. There will be a clear-cut case of pyelonephritis, history-wise. Examination-wise also. You are going CTA, examination, laboratory, everything is showing pyelonephritis. Even BP lowest size, mild, it will come in like the way. Now what antibiotic you are going to give? Piptas. Anyone, sir? Piptas. Meropenem. It depends upon where you are working like the way. I am in Velamal, I will use Meropenem. The problem, if you are periphery, you will use Ceftriaxone. Stable patient, you will start Ceftriaxone, don't worry. Don't hesitate to start Ceftriaxone and send culture before starting antibiotic. Anything you are going to start antibiotic, first you send culture and then you start whatever you want. Once the Ceftriaxone resistant means you will give Meropenem or Piptas, whatever you want. If you started Piptas or Meropenem, Ceftriaxone sensitive means you need to de-escalate. Don't think like patient is not improving, you need to give higher drug. Sensitive means it will 100% it will work. Okay, sir. What is ICMR? There will be antimicrobial stewardship, they will form. 6 months data everywhere they will collect. So our corporate hospital only it will be possibility. There will be different. Yeah, obviously patient not improving means you need to rule out anything surgical, anything other than antibiotic, you need to what all thing you need to know. Stenting needed or not, that only you need to think, sir. Obviously, recurrent UTI, there will be cost, it will be a different thing. The order, at least you know, this will be, initially you start even penicillin. Penicillin resistant means you will give Ceftriaxone. Ceftriaxone resistant means Piptas. Piptas resistant means Meropenem. Meropenem resistant means there will be different concept. UTI will be E. coli, Klebsiella, Pseudomonas. These three only we are routinely seeing. Very rarely we are seeing like gram-positive. Ceftriaxone, okay, sir. Ceftriaxone. You start Ceftriaxone, you sensitive, check for sensitive. Sensitive penicillin means you need to de-escalate. Penicillin very broad spectrum, both gram-positive, gram-negative will cover. Even anaerobic also will cover. What I am telling you is Ceftriaxone, whatever you want, you start based on the stability. Based on this stable patient, you start Ceftriaxone, you send culture, wait for culture. Ceftriaxone sensitive means Ceftriaxone, continue Ceftriaxone. Resistant means you need to switch out to Meropenem. Suppose you start at Meropenem, but patient is Ceftriaxone sensitive culture is coming like that, you need to de-escalate. That much only. Escalate or de-escalate. Urine culture or blood culture, whatever. Sepsis means blood culture also will work, sir. For cystitis, at least you will give different drug, it will be there. Pregnancy always beta-lactam. Non-pregnant woman, there will be multiple drugs, sir. Ceftriaxone or single dose phosphomycin, it will be okay. Otherwise, amikacin, single dose, it will be okay. Don't give multiple dose. 3 grams status, sir. For cystitis. Recurrent cystitis is not going to help. None of the thing it will going to work. They except there will be hip rate, something is there. Other than that, it will be not. It will be same like that. Either way, patient will convince or you will be convinced, sir. There will be nothing. There will be evidence, sir. Cost only you need to find out, sir. Recurrent UTI, there will be none. Treatment or different, sir. Prophylaxis, it will be none of the drug. It will go into work. This may be very tough slide. It will be looking like it will be. You need to understand basics like that. You will give whatever Ertapenem or Ceftriaxone, you will give OD dose. No need to give BD dose. That much you need to know because slow releasing, protein finding. Okay. Then you need to check for hydrobilic or lipobilic. If hydrobilic drug like gram negative or gram positive. Gram negative means you need to give Ceftriaxone, Piptas or Meropenem. It will be work for sepsis. A gram positive for hydrobilic drug vancomycin. It will be for sepsis. Other drug is not going to help in sepsis. Like you are going to give cotrimoxazole or amikacin or like levoflox, it will be for lipophilic drug. It will be for stable patient, OPAT, outpatient antibiotic therapy. It's not for sepsis patient. Your patient in sepsis, you are going to give, don't give Septran or levoflox or amikacin. That drug is not, even linezolid, it's not for sepsis. It will be stable patients. It will be stable patients means OPD patients. Then oral pyrolytic, if you go lipophilic drug, it will be more than 90%. There is no need of give up injection. For sick patients like the way is not able to take oral, then will be considered as IV. Sorry. What case you? What case you are asking, sir?
All the cases for upper respiratory tract or urinary tract, you are prescribing how long?
Upper respiratory tract infection, it will be 3 days only, sir. 3 days. Lower respiratory tract infection, there will be uncomplicated, complicated. Cavity is there, it will be 14 days. Non-cavity, there will be, it will be 7 days, it's enough. UTI, it will be, for cystitis, consider single dose, amikacin or fosfomycin. Otherwise, you will give cotrimoxazole, it will be 3 days. If you are going like pyelonephritis, you will consider 5 to 7 days. But if you have abscess is there, it will be different concept. Evolving abscess is there, it will be different concept. But you need to recurrent UTI, you need to rule out cause. Without treating the cause, there will be antibiotic prophylaxis not going to help. Other thing like time dependent, concentration dependent. This one everyone know the pharmacological time. Time dependent means there will be beta-lactam, ceftriaxone, piptas or meropenem. You need to give divided doses. Not for single dose. You need to give multiple doses, twice or thrice like that. Exception ceftriaxone. Even ertapenem I told. BD means it is not going to help. You need to give large volume, then only it will, because of there will be minimum inhibitory concentration. How long you are maintaining above the level, it will be effective. Beta-lactam like the way, you need to give how long you are maintaining above the level, divided doses, how long you are maintaining. That's why concept it will be very clear. Ceftriaxone leave it, piptas or meropenem whenever you are giving means there will be, you need to give infusion minimum 2 hours. Don't give like direct IV. You need to consider infusion. At least 100 ml NS, you will give for at least 2 hours. Whatever antibiotic you are going to give, you need to check for test dose. This one last case. Young female coming to you with cellulitis, some trauma, and then received antibiotic outside. Coming to you, you are sending culture source, there will be Staphylococcus aureus. You are checking methicillin status, methicillin is sensitive. Why methicillin is sensitive means you will check for culture cefoxitin or oxacillin. You will check for cefoxitin or oxacillin status. It's sensitive means it will be methicillin is sensitive. Now coming to you, either Staphylococcus aureus, skin and soft tissue infection, you are going to deal. What antibiotic you are going to choose? What antibiotic you are going to do? Linezolid, vancomycin, clindamycin or levoflox, what antibiotic you are going to choose? Sir, amoxicillin, sir. Amoxicillin. Any other, sir? MSSC. Amoxicillin. Sir, amoxicillin unfortunately here not there, sir. Linezolid. Any other, sir? Clindamycin. The problem is your case is methicillin sensitive, sir. Here you check for culture, methicillin sensitive. MRSA you are linezolid, it will be okay, sir. For MSSA, not like the way. Your answer will be cephalosporin or flucloxacillin. Cephalosporin or flucloxacillin. You consider. First generation. There will be first generation, it will be more gram positive, sir, cephalosporin. There will be fourth generation, it will be gram negative. You consider. Otherwise, cephaloxacin, it will be easily available everywhere. You consider. For MRSA, you need to consider vancomycin or linezolid. Patient sepsis, you need to consider vancomycin. Patient stable, you need to consider linezolid. Other problem with surgeons everywhere, they doing like tissue. Instead of tissue, they will send swab. Swab is not reliable sample. Don't send swab, pus swab. It will be better try to avoid pus swab. It will be easily, I won't convince them surgeons. If you go tissue, it will be reliable sample. Swab, it will be always confuse you. Maximum time, what organism will get it means pan-resistant Pseudomonas aureus or otherwise cons. It will be commonly we will get it like that. It will be not reliable. You will check for like it will be mild infection or severe infection like the way. Either it will be pus forming or non-pus forming. Up to 2 cm, no need of antibiotic. Up to 2 cm, pus forming. If no pus means impetigo, you consider first generation cephalosporin. Otherwise, if severe means you need to consider injectable. You need to consider. For last case, diabetic foot infections coming to you, examining the patient's diabetic foot, there will be bone is normal, no compartment syndrome, not very deep. It will be superficial only. Still, coming to you, what antibiotic you will choose right now? Piptas. Diabetic foot infection. It's no compartment, sir. Anyway, you need to start. You will give both. Initially, you go broadly. You need to cover Pseudomonas also. MRSA predominantly first you need to target. Then will be either vancomycin or linezolid you need to give. Severity based on the severity, clinical examination. Stable means linezolid, sick means vancomycin. Then Pseudomonas means you need to consider piptas or miraplon, whatever you want. Compulsory you need to cover MRSA. Then only you need to cover Pseudomonas. Okay. That's what I want to emphasize. Superficial infection, gram positive alone enough, but you are extending to soft tissue, even muscle involved, you need to cover Pseudomonas also. Very deep, you need to add it, even clindamycin for toxin effect, antitoxin effect. This much only, it's not much more. You know the diagnosis first and choose antibiotic, what organism you are going to deal. Without that, that one not going to help. Try to avoid like LORIS, EDTA, like other drugs like that way. That's what I want to emphasize again. Thank you. This one my number. This one large discussion I am telling like that. Single forum it will be discussion. It will be very tough like the way this space. I know whatever I will try to explain. Any doubt, please contact me. Thank you.